Good evening, everyone. Thank you, Jeff, for the wonderful introduction. Appreciate that very much. You're a very kind man. I'm really honored to be here to speak to all of you tonight. This evening, I'm going to be talking about federally qualified health centers, FQHC. I think some of you may know that term. And I want to be talking about CMAR Community Health Center and the impact that FQHCs have on the health of low-income people. But before I do that, I want to start by telling you a little bit about me, who I am, where I came from, and how I became a health administrator. My family is originally from Edinburgh, Texas. Edinburgh is in the Rio Grande Valley, about 7 miles from Reynosa, Mexico. It's a really nice valley, very fertile land. A lot of the industry there is agriculture, and so my family was a family that worked in the fields. We started migrating to Washington State in the 1950s when I was a little boy. We would leave Texas around March. We would arrive here in about 5 days. And the reason we came in March, even though the agriculture really didn't start until the middle of April or May, is to try to find housing. My family was a large family of 12. We would work here up until July in Washington State, and then we would go to California. Spent about 3 months in California, and then we would go back to Texas. When I was 14 years old, my dad decided to stay in Washington State. And that was a really good thing for me because I was able to graduate from high school. My family is a large family of 12. I'm the 8th one, and I'm the first to be able to graduate from high school. After high school, I basically had two choices. One, join the military and end up in Vietnam, and the other one was to go to college. I was going to be the first person to go to college, so I decided that that was the right thing for me to do. I was accepted to the university through a special program. It was called the Special Education Program. Then it became the Equal Opportunity Program, and now it's Office of Minority Affairs and Diversity. Without that opportunity, I would have never made it at the university. I just didn't have the grades to be able to be accepted there. When I arrived at the university, it was the fall of 1969. The university was experiencing student turmoil and unrest. This was happening all over the country. The country was in the middle of the civil rights movement and the protests to stop the Vietnam War. And so there was really a lot of activity going on, and mostly it was done by the students. The African American community and its supporters were fed up with this country's lack of progress to end segregation and racial discrimination, so they were fighting back. And this movement was led by the Reverend Martin Luther King, Jr. As a Latino, I could relate to the movement because I had witnessed firsthand racial discrimination of Latinos and African Americans in Texas. I don't know how many of you know about the South, but even today, the South is, I think, behind the 8 ball, if I can use that terminology. I mean, there's still a lot of racism up there. That's the way it was in Texas while I was growing up. At the same time that the civil rights movement was taking place, the Stop the Vietnam War movement was also in full effect. This war was viewed by students as unjust because the students felt that the government did not have a strategy to win or to exit the war. The casualties included a disproportionate number of soldiers who were people of color. I was able to get a student deferment, and that's how I ended up being able to go to the university. A lot of people of color did not have that opportunity, so they ended up going into the military. These movements, to me, they were new. I mean, when I was in high school, I would watch television. I would see, what was going on. I would see how the Reverend Martin Luther King was fighting for the rights of not only African Americans, but all people, all minority people. So even though I didn't know much of it, I got involved. I need some water. There's a glass right there. And so even though they were new to me, I really did embrace them, simply because it was really the right thing for me to do. I had seen all this discrimination occurring in Texas. I saw it on television, and so I got involved. I got involved with student organizations. There was 2 student organizations I was very active in. One was the MECHA. MECHA was focusing on the university, the internal part of the university, and the other one was the Brown Beret, and that focus was in the community. And so we fought for thank you, Jeff. We fought for getting more minority students to the university, and we also fought for getting some faculty. At that time, there were very few faculty members of people of color. Because of the efforts that the students made back then, I think that we helped make the university accept diversity. And over the last 50 years, I think there's been a lot of progress. I think with the student body, I think we have a great, diverse student body. I think we're not there yet with the faculty. Very happy to hear that 30% of your department is people of color or diversity, and so that's excellent. I majored in political science. When I first came here, I really didn't know anything. I mean, I didn't know any profession. And so my first 2 years, I was trying to see how I could help my community. And so I decided that I was going to be a lawyer. And so I majored in political science, heading to law school. But during my junior year of college, I went to work at a community health center in Toppenish, Washington. I was working for the Yakima Farmworkers Clinic half-time, being a community health worker, and I was working half-time as a union organizer for United Farm Workers. And from that experience, I learned that the administrator was going to open up a clinic in the Tri-Cities. And so I went to him, and I asked him if he would consider opening up a clinic in Othello, Washington. This is the hometown where I graduated from, where my family lived. And I told him that the reason it would be a better place than the Tri-Cities was because people in Othello had to go all the way down to Yakima to get health services. The doctors would not provide services to the poor or Medicaid. And he sort of brushed me off. And so what I did is I quit that job, and I moved, because it was a work study, I moved to another nonprofit down in Moses Lake. My job there was to organize the community to petition the federal government to get the Farmworkers Clinic to open up the clinic there. And I spent a few months doing that. And by the time I was ready to come back to school, the federal government had approved a grant to open up a clinic in Othello. And from that experience, I decided that I would become a health administrator. I came back to the university, finished my political science degree, took an additional year, got an economics degree, and then applied to the MHA program. And I was accepted in 1975. The program there was an excellent program. It was one of the top programs in the country, and I believe that it still is. The chair of the department at the time was Dr. Dowling. He provided great leadership to the program. We had a small class. I think it was a class of 20 or 22, and 5 of us were minorities. So there was a lot of diversity even back then at Department of Health Services. So it speaks well of that department. After I completed my MHA, I decided to do an administrative residency at Central Washington Association a hospital in Wenatchee. I spent a great year there under an administrator by the name of Tom Troy. He taught me an enormous amount during that year. Even though I had training in hospital administration, I had always wanted to work in a community health center. You know, that's why I decided to go into healthcare. But the reason that I trained in hospital administration, at that time there was 3 tracks. One was hospital administration, the other one was planning, and the third one was ambulatory care. The track for the hospital administration had more management courses, and I felt that I needed those courses in order to be able to direct a community health center in the future. So I majored in that. After my year was up with Tom Troy, they offered me a job there, but I wanted to work in the community health center, so I applied for a position here in Seattle at CMAR Community Health Center. When I was a student, I've been working with some of the local students, health sciences students, to get that clinic open. I mean, my application to that position, I didn't think it was going to be taken seriously, simply because I really did not have the experience to administer that clinic, even though it was brand new. But I got the opportunity as a result of probably nobody else wanting it, and so I ended up with it. I'm going to talk a little bit about who community health centers are, and then I'm going to talk about CMAR. Community health centers were born out of the civil rights movement when President Johnson declared war on poverty. In the 1960s, there were millions of Americans that were living in poverty. Many families, especially in the South, and remember that I came from the South in Texas. I mean, all that area was a very, very poor area. And many people were living in an environment that were similar to third world conditions. Housing that didn't have foundations or insulated walls, with no running water, bathrooms, or refrigerators to keep food safe. Low-income families had no basic health care and needed a place to go. I mean, I think Martin Luther King once made a statement, you know, that it was unjust for people of color and poor people not to have health care. And so even back then, he was recognizing that that was a major, major problem in the communities where poor people live. Funding for the first 2 neighborhood health centers, one in Boston, Massachusetts, and the other in Mount Bayou, Mississippi, was approved in 1965. In addition to providing primary care for the community, health centers also envision bringing about social justice change to address issues like improving living conditions, adding clean water supplies to homes, improving sanitation, building latrines, and training the community on healthy behaviors. And so they were back then looking at the social determinants of health. And a lot of community health centers, you know, have been doing some of that work, you know, for many, many years. All federally qualified health centers must be located in or serve a high-need community, such as a medically underserved area, and must have a mission to improve the health status of underserved populations in their targeted community. So the target for community health centers is the low income. It's the Medicaid population. The health centers need to be governed by a community board of directors. 51% of the members need to be consumers of the clinic. They're required to serve all people regardless of ability to pay. We are not free clinics. We charge patients on a sliding fee scale based on their income and their family size. At the minimum, health centers need to provide primary medical care, dental care, and behavioral health. Health centers also are required to provide supportive services such as transportation and translation. We also are required to have referral arrangements with hospitals and specialists. One of the biggest problems for community health centers is specialty care for our patients. Most hospitals, most doctor's offices don't want to see our patients. And the reason is that Medicaid pays them 20, 30 cents on the dollar. And so they restrict the number of patients that they will see. And so in all our clinics that we have in CMAR, that is the most pressing problem that we have. Now there's some benefits for health centers. We're eligible for 330 federal grant. In our case, in CMAR's case, we get $15 million a year from them. We're eligible for enhanced reimbursement revenue from Medicare and Medicaid through a prospective payment system. Now this is a really big thing for community health centers. This happened, I think, somewhere in the late 1980s. I think it was 1988, somewhere around that area. But for the previous years, we had been paid similar to other providers, even though the majority of our patients were Medicaid or uninsured. And so Congress made some special provisions for us to be reimbursed like hospitals were reimbursed in terms of their cost. And so in 1988, we were able to get our cost. That improved our reimbursement rate substantially, and so that a lot of the clinics were able to grow as a result of that. We're also eligible for medical malpractice coverage under the federal tort claim. Now this is also very big. I mean, this probably saves our organization $3 to $4 million a year by having the federal government insure our providers. So that's another big thing that happened. And then we're also eligible, especially health centers in the South, for the National Health Service Corps and the loan repayment program. And this is very important for us in order to recruit providers. Then finally, we're also eligible for drug pricing discounts for pharmaceutical products under the 340B, also a very big thing for us. I think in our case, we probably end up saving about $5 million a year on this particular program. So health centers have always been viewed by Congress as sort of the safety net for the poor. We have bipartisan support. Both Republicans and Democrats support us. In the past, we have been viewed as the alternative to universal health care. Nationally, health centers disproportionately serve the poor, the uninsured, and the publicly insured patients. 71% of the patients served are at or below 100% of the poverty level compared to 15% of the U.S. population. 28% of health center patients were uninsured compared to 10% of the U.S. population. So the focus is the low-income people. Health centers serve a very diverse patient profile. 36% of the patients are white, 34 are Latino, 19 are African American, and 11% are patients of other minorities. And so it is quite diverse. A lot of time people think that that community health centers just serve minority people, but we serve everyone, regardless of ability to pay. For the last 40 years, I've been working as executive director of CMAR Community Health Center. Our first year budget at the clinic consisted of a $200,000 grant we got from the federal government. We had 8 employees. We saw approximately 2,500 patients the first year and provided 8,000 visits. Early on, we decided that our organization was going to follow 3 main principles. The first principle was that we were going to run the organization as a business using sound business principles. We were going to be in the business of serving people. The second principle was that we were going to deliver services in modern healthcare facilities. Back then, when community health centers started, most of the clinics were operating on storefront operations. We felt that it was important for our patients to receive care in nice facilities. And then the third principle was that we were going to provide as many services under one umbrella organization as we possibly could, and that we were going to diversify our funding sources. So we began to grow. One of the reasons that we've been able to grow as large as we are is due to a decision that we made in 1992 when we partnered with our sister healthcare centers to start a managed care insurance company, Community Health Plan of Washington. The first major decision that we made after we set up that nonprofit was to hire Dennis Braddock as our CEO. Dennis Braddock was retiring from being chair of the House of Representatives Healthcare Committee. That gave us instant credibility, I mean, almost overnight. We have been meeting with people in the community, and the insurance companies met with us, trying to discourage us from setting up this company, and they kind of laughed at us that we were not going to be able to make it. And the reason that people didn't think that we were going to make it is because we didn't have any money. And they were right. You know, we did not have any money. We were flat broke. But what we did is we made arrangements with Primera to lease their license and for Primera to be our third-party administrator to process our claim. That was a really smart decision because we had been managing, that's when the state decided to put Medicaid in the managed care program. We have been managing our patients. You know, we were trying to keep our patients healthy. That's what we had been doing for years. And so we had substantial amount of savings as a result of the way they were reimbursing us under Medicaid. And so we made an agreement with all the community health centers to keep our pool savings in the company. They were allocated to us, and we gave it right back to the plan so that we could build the reserves. And so it took a few years. I don't think it took more than 3 years. And we had enough reserves to be able to go independent. And I think that was a major decision because if you look at our net equity, probably half of our net equity is a result of the pool savings that we've made over the years by making that particular decision. CHPW today has 300,000 enrollees, has total assets of $500 million, revenues of $1 billion, and net assets of $139 million. All the community partners have done very well with this arrangement, and we have been able to generate enough pool savings so that all the partners have been able to grow. So if you look at our community health centers in this state, you know, we are in very healthy positions. We've been able to improve our facilities. Everyone has very, very modern facilities now. During fiscal year 2018, we served approximately 305,000 patients. We had 100 sites in 12 counties that we provide medical, dental, behavioral health services, and a variety of other services. We're probably one of the most comprehensive nonprofit in the country. If you look at our operations, we have so many services under one umbrella organization that I don't think there's very many other organizations that are as comprehensive as we are. Our patient profile is very diverse. 39% are white, 24% are Latinos, 4% are African Americans, 27% are multiracial or unknown, and 6% are minorities. 65% of our patients are at or below 100% of the poverty level. These patients are served by 2,600 employees that work for our organization. Since the state adopted the Medicaid expansion, CMAR has helped over 160,000 individuals with insurance enrollment into the Medicaid exchange program. That's an awful lot of people. The number of CMAR patients with Medicaid jumped from 44% in 2010 to 63% in 2015. You know, what does that mean for us? It means that some of the individuals that were previously uninsured, we enrolled them into the Medicaid expansion, and that has substantially improved our ability to raise revenue. The uninsured population decreased from 41% in 2010 to 17% in 2017. And so a lot of the community health centers are in the same shoes that we were in, and this has helped and added additional revenue for us to be able to provide service to our patients. CMAR combined revenues were a little over $300 million in 2018. Our equity was a little over $118 million the same year, 2018. If you look at slide 24, it shows sort of the relationship between revenue and equity over time. You can see that the impact of the enhanced reimbursement rate and the Medicaid managed care program, which started in 1988 and 2010, this graph shows our revenue and our equity where it really began to grow a lot faster. So you can see it was very stable, very low in terms of revenue and equity, and then all of a sudden the changes happened, and look what happens to our revenue and to our equity. And so those two congressional changes that occurred has helped us tremendously. Now, one of the things that I'm really proud of our organization is our advocacy that we do at the state level. I think we're probably one of the few community health centers in the state, if maybe the only one, that has been willing to stick out our necks for the poor. For example, when Governor Lowry left the farm worker community out of healthcare reform, I think many of you are probably too young to know, but Washington State passed healthcare reform in the 80s. But there was a group of people that were left out, and these were farm workers. And we stuck our neck out. I mean, we fought the governor. I mean, we fought the legislature and the governor up until the very, very end, and we brought a lot of attention to this issue. The same thing with farm worker housing. When people were living in tents, I mean, these were tents, and they were being licensed by the Department of Health, and we fought with the state and the governor as well to try to change that. It took us like 5 years to do it, and finally the Fed stepped in and said, no, you can't license this type of tents. They have to be OSHA tents. You want tents? No problem, but they have to be OSHA tents. They have to have certain size ceiling, I think 7 feet or 8 feet. They have to have a stove, they have to have power, they have to have a refrigerator. The tents that were being approved, they were basically a tarp between two trees. The stove was some bricks on a grill. The refrigerator was this quite big refrigerator with no power in the field. This is in the middle of the field. And the water supply was a hose from the farmer's house to the camp. And so I'm really proud of our organization willing to put our neck out there. And believe me, a lot of people try to shop that off, but we were successful in not getting it completely torn off. Now, what are we doing to be successful in the future? And I'm running a little late. I'll finish up in a couple of minutes. We're really working hard. I'm going to summarize. We're really working hard to prepare our organization for the coming years for value-based care. We've been investing some money in our infrastructure to make it easier, to implement our process improvements. We are accepting greater risks. We have contracts with all our managed care companies now. We have over 105,000 Medicaid patients where we are at risk at. We're developing additional programs. We're trying to continue to work on improving the social determinants of health. We're now building affordable housing. Right now we have a 70-unit housing complex up in Vancouver, Washington, that we're going to be finishing up this summer. Community health centers like CMAR, we have been able to reduce health disparities, and we are achieving health equity for patients that we serve. We improve access to primary and preventive care to the poor. We are cost effective. We provide high quality care. We manage chronic illnesses. We improve birth outcomes. And in rural areas especially, we create jobs and stimulate the economy. I have been very lucky to work for this organization for 40 years. I mean, I count my blessings. I want to thank the University of Washington, the School of Public Health, and the Department of Health Services for preparing me to lead this organization. It has been a wonderful ride. I'm still not thinking about retiring. People are asking me when I'm going to retire. I'm still having a lot of fun, and so I probably won't retire anytime soon. So thank you very much for listening to me. I'm sorry that I went over.
We have a little gap. Okay. You want it? I can take that.
Okay.
I just, you're such a hero to me and to all of us who care about health equity and care about trying to improve the lives of people in our community. It's astounding. I realized I was said, what is that feeling? And it was, I had this high heart rate the whole time hearing that story because it's a really neat story. And yet I also want to say, you know, when I saw those pictures of the 60s, I realized how far we've come, but I actually thought you did a nice job of reminding us how far we have to go.
We have to go.
So
thank you very much. Yeah.